Okay, so what we're going to do over here is I'm going to take you through um, the APG exam on the to test patient, just kind of how we do it. So patient, test patient 9 is our patient. Remember, this is the patient that we have already gone a little bit over with regards to their different kind of complaints for an ingrown toenail as well as heel pain, both on the left. I guess I said the right great toe. Okay, whatever, to make it complicated that way. So it's the right great toe. I'm going to take a couple of things off over here quickly. No, honestly, we're just going to go to the exam. So we've already done our history, and now we're going to the physical exam. We go into the objective physical exam, and the APG exam is our kind of workhorse for this. And you can see it's a long form. We use it for lots of different things. Not everything needs to be mentioned also too. So we start off with constitutional mental status. Most of our patients are going to be alert and oriented ×3. That basically means that they know who they are, they know where they are, they know roughly when it is. Okay, we might have someone that's confused, maybe someone with Alzheimer's. They may be poor story that they just kind of they can't remember when things happen. They're just kind of discombobulated. But most of our patients are going to be healthy here, and they're going to be alert and oriented ×3. Body habitus, if most of them are well developed, some may be overweight a little bit, and some are obese, some are underweight, some look like they're just not really taking care of themselves. Again, most of our patients are going to be okay. Let's just well nourished, normal BMI. Some will be overweight also. Quite a few of us will be overweight, but not necessarily obese. We start off with a cardiovascular exam. Remember, this is something that you're going to be with the physician when this is being done. But just to kind of know what we're talking about, we have a pretty regular routine of how we go through things. And we'll go through a vascular and neurological exam as is appropriate for that complaint. If someone's coming with a wart, we're not going to do a full neurological examination. If they have an ingrown toenail, we're going to do a full neurological examination if they don't have a history of diabetes or circulation issues or things along those lines. So just kind of follow our lead with regards to that. When we do the exam, it'd be good to see if we had a foot. Oh, wait a second. Okay, so we've got a foot. Okay, so when we talk about the dorsalis pedis pulse, the dorsalis pedis pulse is on the top part of the foot. We'll typically be feeling it like this, putting our hands across the top of the midfoot like this, and we'll feel a pulse like that. The posterior tibial pulse will typically reach around the corner, kind of going like this to feel behind the ankle bone on the medial side of the foot here. Okay, so we'll kind of say, okay, the DP pulses are 2/4 bilaterally, or 2/4 right, 1/4 left. Again, the choices here is 0, meaning you can't feel pulses. 1, it's weak. 2 is kind of normal. 3 is pretty strong. 4/4 is bounding. Non-palpable is the same as 0/4. We'll typically use the numbers. That's what I do. Dr. Fernandez may say non-palpable, but most of them are going to be the 0, 1, or 2. So you would just kind of put those in like this. PT pulse, also 2/4. Sometimes they might be 1/4, whatever. Okay. Capillary refill time. It has to do with when we touch the tip of the toe and let go. How many seconds does it take for the blanching or the lightening of the toe to turn pink again? Okay. So we would say, 1, 2, 3, and it's either instantaneous, immediately shows up, or 1 second, 2 seconds, 3 seconds. More than 3 seconds, that you've got some significant circulatory problems also too. But we'll say what the capillary refill is on the right or the left. If it's something particular, like we say, it's 1 second, but for some reason, on the right third toe, greater than 3 seconds, that's where you would kind of put that there. Okay, right third toe is greater than 3. Right third toe greater than 3 seconds. You can kind of put that there. Hair growth is whether there's hair on the foot or the toes. That is an indication of circulation. We're typically looking at the toes for that. If it's present, if there's abundant hair, it's present. If it's absent, there's no hair. If there's just like a couple of strands, and then we see decreased hair. Edema has to do with swelling. We describe swelling as being either non-pitting or pitting. Non-pitting means it's just swollen. You can tell that there's swelling there, there's fluid there. Pitting means when you push on the foot and you let go, there's an indentation that's left afterwards. And depending on the severity of that, we'll say it's 1+ or 2+ pitting edema. Edema that is not general, but localized to an injury. If they've got a swollen fifth toe because they banged it, we'll say it's localized to the injury site, and we'll say that it's, let's say in the case of this patient, no, but we might say that located to the injury site. Yeah, we'll just put it here. So we'll say it's located to the injury site, and it was, they got an ingrown toenail. We'll say they've got some edema on the ingrown toenail. So they have a right ingrown toenail, and it's not an injury, but we'll say edema noted lateral border right hallux. Okay. Yeah. Do they have any varicose veins? How bad are they? Where are they located? It's there. Skin temperature. If everything is good, skin temperature tends to be warm. If it's hot, there may be infection or gout going on. Cool may just be that they have cold feet, or it might be circulation related, but we'll tell you what's what. Dependent rubor means is there redness, like when the foot's down, does it turn red? And that's usually for somebody that's old and has some circulation problems. Now we talk about advanced trophic changes. This is important for people that have bad circulation or that may be qualifying for at-risk foot care, like our routine foot care. We say routine because it's easy, but it's really at-risk foot care. It's not routine. And things like decreased or absence of hair growth, nail thickening, skin discoloration, like dark brown skin where the skin's normally light, thin and shiny skin, very kind of frail looking skin, looks like it splits if you kind of put pressure on it, looks like you might tear skin, and then rubor or redness of skin also. These are all circulation findings, negative circulation findings or bad circulation findings. And for qualifying for at-risk foot care, to use certain modifiers, Q8 modifiers, for example, you have to have so many of these things not working out. Otherwise, their care is not covered by Medicare and they have to pay out of pocket. So this is where we document that. And it'll be either on the right or the left side. So it might say, this patient has decreased or absence of hair growth, they got nail thickening, and the skin is thin and shiny in texture. Okay, so that's one way that works towards qualifying. Neurological. We might just kind of touch the foot. Can you feel me touching you here or there, just for a general, is general sensation intact? Okay. If they're diabetic, we'll typically do, or if they have a particular neurological numbness kind of complaint, we may do a Sims-Weinstein monofilament exam where we use that little wire and say, I'm going to touch you in your toe, the ball of the foot, the arch, or the heel. Don't look, close your eyes, turn away. Let me know if you feel it. If you can, tell me where you feel it. And we'll say, whether that is intact to all sites or is it diminished in any particular locations. Okay, we'll specify. Sharp dull sensation is whether we touch something pointy versus something that's dull. Can they tell the difference? Vibratory sensation is the tuning fork. Remember, we say you can feel vibration. Tell me as soon as you stop feeling it. Just say it's just pressure, because it'll be vibrating first and then it'll just switch to pressure. Ideally, they should feel it just before I stop feeling it, before the doctor stops feeling the vibration. They should stop feeling it just before that. And if they feel it fine at the toe, we stop at that. If they don't feel it well at the toe, we'll check at the first NP joint, or we'll check at the malleoli, or we'll check all the way on the tibia, because we expect those sensations to be working better the further proximal we go. Proprioception is the position sensing. Okay, so vibratory would say it's intact, or it's diminished to the toes, for example, something like that. Proprioception is it's either intact or it's not, or it's diminished. That's where we take the toe. We say, tell me when you stop feeling me moving it either up or down. Just say up or down. If they feel it right away, it's normal. If I've got to go quite a bit and then they finally can get it right, then that's diminished. If they don't feel it all, then it's absent. Okay. Most of our healthy patients don't have a problem with that. Deep tendon reflexes, sometimes we'll check patella or Achilles reflexes. This is where you kind of find it. And it basically just says whether or not they're normal, whether hyperreflexes like too aggressive, whether they barely feel it or there's no reflexes. Tinel sign is something that we use, positive or negative, to check for tarsal tunnel. We'll look at the medial side of the ankle and we'll tap underneath or just behind the malleolus, the ankle bone on the big toe side. And if they feel a little zing going into the arch of the foot, that's a positive Tinel sign, and it's a test for tarsal tunnel. Mulder's sign, I'm just going to say negative for that. Mulder's sign is for neuromas. we'll be checking to see if when we squeeze the foot from side to side, do they have pain? If we squeeze the foot from side to side and push in the second or the third interspaces, do they get a zinger or a pop or some kind of abnormal sensation? That's a positive Mulder sign, whether it's in the second or the third interspace, will let you know what's felt. Then we go to our dermatological exam. And that's a skin, generally speaking. Is the skin warm, dry, supple in a healthy person? Is it thin, shiny, or atrophic, meaning very frail looking, like is in someone with poor circulation? Is it cool to touch, which would be abnormal? Is it erotic? Is it dry? Is it kind of just like dry skin? Or is it scaly? Difference between dry and scaly. Scaly would be more like an athlete's foot, where not only is there scaling or peeling, but there's some redness involved. Maybe the patient is also complaining of itching at that time too. But let's just say for our patient here, everything is warm, dry, and supple. Okay. Yep.
You're recording?
Yep.
Okay.
Hold on 1 second. I'm going to pause the recording. If I can find out where to pause it. Here we go. And we are. Okay, we're back. Okay, so anyway, those things. So in terms of the scaling versus everything like that. So rashes, if there's rashes present, you can see there's descriptions here. Again, we would explain that there's a rash. Scaling, and we mentioned erythematous means redness, vesicular or hyperkeratotic, silvery, something for psoriasis. Pruritic means it itches, painful. And macerated is like when it turns white, like if you've been in the swimming pool too long. That's sometimes from athlete's foot infections that occur kind of between the toes, typically between the fourth and fifth toes. Palpation, nodules noted. That would be for like plantar fibromas here, any lumps and bumps, any place that would not otherwise be a corn or something like that. Erythema is redness, where is it's absent, or it's present as noted. We might say, it's so erythema, we have a right big toe, so it's noted at the lateral border of the right hallux nail, because remember it has an ingrown toenail, so that's not an unusual place to have erythema. Ecchymosis is bruising, right? So where is it? Okay, and again, these are for right and left. Hard corns. Hard corns are typically found on the knuckles of the toes, sometimes at the tips of the toes, or even on the sides of the foot. So if you look at hard corn locations, hallux, second toe, third toe, fourth toe, fifth toe, first met head, fifth met head, other specify. I just kind of mentioned where it is, right? So whether it's bottom or top, you can mention it. Let's say if I said it's the hallux, let's say it's the second toe and the fourth toe. Okay, and I might say it's at the right PIPJ second toe and distal fourth toe. And we would let you know that if that needs to be dictated that way. Okay. Same thing goes for the other toes. Soft corns. Soft corns, if you notice, the choices are web spaces. Soft corns are typically macerated. They're soft corns that tend to be between the toes in the web space. The moisture and that's present there, along with callus, tends to turn it kind of white. And you have these soft corns, and like fourth web space, most common location for that. So that's where soft corns are. Calluses are broad sheets of skin. They're going to be around the heel. They're going to be on the bottom of the foot. They don't have the hard cores, so they don't look like little mountains typically. Okay, and you can see where we have the hallux IPJ is here, either on the side or on the bottom. Plantar medial forefoot, submet 1, 2, 3, 4, 5. Plantar lateral forefoot, plantar medial midfoot, plantar lateral fifth met base and heel. Fissures or cracks in the skin. They can be in the toes, they could be in the ball of the foot, in the arch, and commonly around the edges of the heels. Fissures, they're deep cracks that can tend to be pretty painful. They may even bleed. Okay, so then we have rookas, we have warts. Okay, so warts, if you kind of look at it, these are descriptive terms of them. They're present and unnoted, because this is used in follow-ups, not just new patients too, because as patients are improving or worsening, we will update this exam for each encounter. So hyperkeratotic, that's callus. Papillomatous is like little like finger-like projections, devoid of skin lines. The picture skin lines or fingerprint lines that diverge around, like a knot in a plank of wood, the grain goes around it. That's what divergence of skin lines means, and that's common with warts. pinpoint bleeding. They have little blood vessels in them. So as you shave down a callus, it doesn't bleed. If you shave down a wart, you get little pinpoint bleeding. And as that improves, you might see no pinpoint bleeding. Maceration may happen. That's the whiteness. If they're using a Nucara wart peel or an over-the-counter product that has acid in it, it tends to macerate the skin. Warts tend to be painful on side-to-side squeezing compression. It can also be painful with direct compression. Obviously, if it looks like it's resolved on a follow-up exam, or if there's normal return lines, that usually those are positive findings. Sometimes there'll be blistering if we're using wart peel or another acid or another treatment. And sometimes there might even be a little bit of local inflammation or infection that has erythema with it. Again, right or left. You're right there, thank you. Okay, so now we get to the, I'm going to pause this here. Let me pause it. Sorry. Okay, so we're back. We're back. All right, so we went over other skin lesions. Yeah, so other skin lesions, these may be other types of moles or different things, and these are different things that we look at for it. So if we see another skin lesion, you might say that there's there's a little skin lesion that measures this, or that, and it looks this way. So you would actually kind of put the descriptions of the skin lesion. Let's say it was raised, it had regular borders, it's pigmented, it's non-tender, and you can say, where is it located? It's on the forefoot, and that it measures 2 by 5 millimeters. Okay, and that would be kind of how you would document that. Now, when we talk about nails, there's lots of things with nails, right? So in the case of this patient, they've got an ingrown toenail. So we're saying that they have a basically an incurvated toenail. Okay, we can say it's long or short, might have been cut too short, right? So it was cut too short because the patient said that they trimmed it a little bit too short, and that there's pain on palpation. And we'll just specify that where is it? It's on the hallux, and it's the right. So it's the right hallux, lateral border, and we can say that purulent drainage is present. We got pus. Okay. And no ascending cellulitis. That means they don't have red streaks going up past like the toe. There may be local redness, which we have over here, as there being, erythema is present along the lateral border of the right hallux now. Okay, so we've got that there, and we'll just say all the other toenails are normal there. Okay, are there any ulcers? So ulcers are breakdowns or wounds on the skin, more common with diabetic patients. There's different reasons ulcers can happen. This is a little ulcer on my finger from where the burr got me a couple of weeks ago, but it's almost healed, so I have no band-aid now. Anyway, where the ulcer is located, you would say, let's say if it's submetatarsal head 1, and then the stage, and this has to do with the depth of it, and there's different explanations of that. Most of the ulcers we see here tend to be stage 1 or 2, but they can be stage 3, going down to joint capsular 4, which is even like into bone. So, but that's ulcers. And by the way, if you want to take anything off, let's say if I were to take that away, I have to click it. If I don't save it, it stays on there. If I save it now, the clicking off is now saved. So now we have our toenail shown. We go to our musculoskeletal exam. Muscle strength is graded 1 to 5, 0 to 5, I should say. 5 out of 5, which is our most common thing. We say 5 out of 5, all groups, both feet. That means patients can move down, they can move up, they can move in, they can move out against resistance. Okay, and that's full strength. That there's movement with gravity, there's movement independent of gravity, there's movement against gravity, there's movement against gravity and resistance. These are all different things to judge strength. And normally we're 5 out of 5. Most patients have that. Range of motion. Most people are going to be either one of these two, meaning that there's normal range of motion, dorsiflexion, plantarflexion, inversion, excuse me, that was eversion or inversion. Lots of our patients, particularly plantar fasciitis patients, have limited dorsiflexion. Everything else is normal, meaning that the ankle can only go so much, and that tightness tends to cause lots of problems mechanically in the foot. So we would put down, if everything is normal, but the dorsiflexion, we could put that. If we want to just be piecemeal, we could just say limited dorsiflexion of the ankle. Midfoot hypermobility, something that we see with bunions. Limited dorsiflexion at the first MPJ means that the toe doesn't move up most. That would be like with hallux limitus or arthritis in the big toe joint. Tracking on range of motion of the first MPJ is when we try to move the toe up, it tends to go like that way, or like, I can't do it. It's not, it tends to go, when you move it up, it tends to go like this instead of just up normally. Yeah, I know that's down, but you know what I mean. Crepitus means when you move it, it goes crunch, 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 crunch. We can feel it. And these all are just limited eversion or inversion. It has to do with the rear part of the foot. Sometimes we'll say we don't assess it because of injury, meaning, you know, they've got broken bones and things. We're not going to yank on their feet. Anyway, so, you know, most patients are going to have limited dorsiflexion that have plantar fasciitis. The left foot is the side that has, but I'm going to put it on both here. Deformities of the foot, these are all different things. So medial, first MPJ prominence, dorsal, first MPJ prominence. A hammered hallux is a hammer toe of the big toe. Contracted lesser toes are when you have hammer toes like this. So that means all of them are contracted or the individual ones are contracted. You can click whichever ones are. Usually when I have you, by the way, you can click several different things on these in order to take off what you don't want before you save. Subluxation or dislocation means that these joints, the toes are kind of elevated compared to the rest. They're not just hammered, but they're actually shifted upwards. And we'll see some patients with that, where the toes floating in the air, even though it's straight. And sometimes they'll be going this way or this way, and they'll kind of cross over. Not uncommon to have a second toe crossing over a big toe. Dorsal midfoot prominence is a prominence here. Posterior heel prominence is here. Soft tissue masses might be like ganglion cysts. They'll be in different locations. Plantar soft tissue mass typically is a plantar fibroma. It looks like a little knot over here. And then anything that there's something else, you just say other, and you would just say whatever the problem is over here. Take that off and save it. Okay, pain on palpation. This is just a catch-all. So in this case, we have heel pain. So this patient has tender at the plantar medial tubercle of the right, tubercle of the left heel. I guess it's tenderness at the and I am fine with the MCT of the affecting tubercle of the left heel. And I might even say that there's no tenderness at the tarsal tunnel or PT tendon, because some people that have heel pain will have tarsal tunnel syndrome. So we'll check for tarsal tunnel syndrome, or we'll check to see if they have pain with inversion along their posterior tibial tendon, which sometimes can mimic heel pain in some people. Is there pain on passive range of motion? In other words, if I move the foot this way, that way, is there any pain? And let's just say it's none. Is there any pain with active range of motion? Push against, move your foot up, move your foot down. They're moving, that's active range of motion. Passive is I'm moving it. Active is they're moving it under my command. And let's just say it's none. Crepitus, is there any crunching? None. None. Okay, and then arch type. Increased, high arch, decreased arch, normal arch. Let's say the right is normal. Let's say the left is decreased. And then other structural notification. So if they have rear foot valgus, that's where the heel kind of goes. This is big toe, this is little toe, where the heel goes that way. Rear foot varus is that way. Midfoot planus is a really flat foot. Midfoot cavus is super high arch foot. Forefoot varus is the front part of the foot is twisted this way when the heel is, when the leg is straight. Plantar flex first ray means this part of the foot is down compared to the other part. Hypermobile first ray is this moves up and down very easily, typical with some of our bad bunions. Plantar flex first metatarsal, a lot of this bone is down a lot. Genu valgum is knock knees. Genu varum is bow leg. Metatarsus adductus is that C-shaped curvature where the whole foot kind of angles this way. And we see those sometimes with bunions. But let's just say for the sake of argument, this has none. And this one has none. So that is our entire history, our physical exam history. Okay. And we can do other structural notions. We can say something about how they walk or things along those lines also too with their gait. But we save it. And now when we check, here is our APG exam. All the different things that we put down here are noted in there. And that is how we do the APG exam. That's all, folks.